This podcast is brought to you by ProLongevity, the award-winning 8-week program that can transform the lives of people with prediabetes, type 2 diabetes, and many other lifestyle-related illnesses. Founded by Phillips, the pharmacist who gave up drugs.
Hello, and welcome to the latest edition of the ProLongevity Podcast. As those who've been following the series for a while will know, I've become absolutely fascinated about the relationship between metabolic health and mental health. And we've done a series of 3 on that subject. Do review some of those if you haven't seen them. But I'm delighted to welcome today a consultant psychiatrist and has become recently a friend of mine, Sunny Kaler, who's NHS psychiatrist with a number of special interests and who's become more involved in the public health collaboration, has become interested in this whole relationship between food and mental health. Sunny, welcome to the podcast.
Thank you so much, Graham, and I'm very, very pleased to be here, to be speaking with you. I know we speak a lot offline, but making it official, it's an exciting thing for me. Thank you.
Absolutely. So tell us a little bit more about yourself, professionally, your personal journey, how you ended up here.
Absolutely. Yeah. So I'm a forensic psychiatrist and, as you said, working in the NHS. So I did my training, all of it in the NHS, but I was actually born and brought up in the Philippines where I did my so nice tropical country, and people always say, "Why are you here?" It's because I like the cold. So why I'm in the UK. So yeah, so I did my psychiatry training all over the country, really, starting in Nottingham, then Newcastle, and then moved to Sheffield, where I live, and became a forensic psychiatrist in 2017, and did my first job in Doncaster with the Learning Disability Service. But then since 2018, I moved to Rampton Hospital, which is one of the high secure hospitals in England. But if we include Scotland, it'll be like one of 4 high secure hospitals, which is an NHS hospital for offenders.
And just what are the typical patients like at Rampton then? Because it's not it's obviously different from your local DGH.
That's right. Yeah. So essentially, how it works is that when patients get referred to the NHS, say for example with mental health difficulties and such alike, they go straight to the primary care services, which is our GP, general practitioner in the UK, and they get referred, they get interviewed, they get assessed, and then the GP will conduct their assessment and make a diagnosis and treat where appropriate within the primary. And then a patient may move up the ladder from the primary care services to secondary or tertiary services, or what we call special services as well. So, for instance, if the diagnosis is such that the patient cannot be managed in the primary care services, then they can get referred to the secondary mental health services. Now, in secondary mental health services, there are lots of different branches of psychiatry. So, for instance, if somebody has the first episode of psychosis, then they might go to a service called the Early Intervention in Psychosis Team, or its acronym being EIP services. If somebody is pregnant and develops mental health difficulty, there are perinatal psychiatrists. And somebody's elderly, there's an old age psychiatry. Some children, there's a CAMS, we call child and adolescent mental health services. But then focusing on forensic psychiatry, so it's a branch of psychiatry that deals with the law as well. So what it means is there's an interface between the mental health and the mental health law. So essentially, deal with people who have offended, or those who pose a risk. Their mental health situation or presentation is such that it's associated with risk of harm to other people. So they then get referred to forensic services. And now in forensic services, there are different tiers as well. You have what's called community forensic services, where somebody in the community might be a risk to others, and then the EIT services might refer to the forensic services in the community, and then they will do their own assessment, particularly focusing on risk, and then offer management. Now, if somebody is not being able to be managed in the community, then they get to the secure services. Now, the secure services are of 3 tiers. You have the low secure, the medium secure, and the high secure. Now, patients can go or be referred in those services via 2 routes, at least 2 routes. One from the general services. So if people were detained under the Mental Health Act, this is the law which is used in order to safeguard people with mental health difficulties in terms of their detention or treatment whilst they're detained. So people like you and I, if we became unwell, and we can be detained under the Mental Health Act, and that's called the civil section. But if you and I became so disturbed that we pose a risk to others, we can be referred to any of those 3 levels of security, depending on the gravity of your risk that you pose to other people. So that's one route. So via the general services, and you go up the ladder depending on your risk.
Yeah.
But there's also the majority that we deal with are those that are dealt with by the court system, and either directly from the Crown Court or magistrate, or those who have gone through the prison system or are serving sentence in prison. So the Mental Health Act allows us to transfer patients directly from court or from prison, depending on where they are in the journey of their prison sentence. So that's basically what we do. So I deal a lot of I have lots of dealings with the court, with the Home Office or the Ministry of Justice, and other psychiatric services.
And so that's not the usual route, and it's not the everyday experience of most people. It's interesting and specialized. So in as much as there's an average client or group of clients or patients, just characterize for me, just talk to me about an average day in the life of Sunny Kaler then. What would that like, your working life?
Well, first things first is I drive a lot. Hence, I was telling you one day, I think I've listened to your podcast and many other podcasts. It's because that allows me, like the drive to work and from work allows me at least an hour of me time, listening to things that I truly enjoy. And our day-to-day work really is dealing with patients, but that's not like a 9 to 5 patient-centered work, if you like, because after we see your patients, we need to produce quite a number of reports. We have to do lots of meetings, clinical meetings, about a particular patient or about a particular ward that is dealing with that particular patient. So the reports would entail like reports for the court or reports for the Ministry of Justice. And sometimes we also produce like reports for tribunals, because patients, in order for them to be safeguarded, they need to be independently tried, if you like, to see whether they are legally detained or whether the detention is still necessary for their mental disorder. So we have lots of, shall we call, admin work as well for that particular patient. So that's one. But we also have lots of managerial. As a consultant psychiatrist, we deal with managerial aspects of our work, which is like maybe to do with like supervision, for instance, or dealing with like hospital policies and procedures. And there's different branches in that. And that happens between 9 to 5, Monday to Friday. But it's not strict 9 to 5, because as doctors, you sometimes go over your contractual hour. And as many other doctors, we have on-call responsibility as well. So where we deal with emergencies in the hospital where I work in Rampton.
And what about talk to us a bit more about your clinical caseload?
Of course. So Ramsden Hospital has 5 different services, three national services and 2 general services. So the 2 general are male personality disorder patients and male mental illness patients. So mental illness being schizophrenia or a combination of schizophrenia and mood disorders, or like substance use disorder that has led to psychotic symptoms. So those are like the mental illness service. And you have the personality disorder, where people have either ranging from above moderate to severe personality type. And in the old classification that we use, the ICD-10, there are different types of personality disorder, like emotionally unstable or borderline, the antisocial or dissocial PD. So those are like the other types of services. And then there are 3 national services. You have the national learning disability or intellectual disability, national women's service, and the national deaf service or hard of hearing patients. So half of my work is in the male mental illness, and the other half is in the national high secure deaf service, which also has links with prisons nationally. So we see deaf prisoners anywhere in the country in order to provide assessment and management.
So let's start with a kind of helicopter view. As I said to you previously, I think I've got a reason. I count myself incredibly lucky that I've never really suffered with mental health problems, but I was brought up in a household full of them. My father's bipolar. My mum had this sort of long cyclic psychotic depression. And I think if you've never really enjoyed good mental health, it's pretty hard actually to conceptualize what good mental health is. And I think if you've never had a mental health disorder, it's pretty hard to understand. I mean, why don't you just pull yourself together? Where's the problem here? How would you characterize what good mental health actually means? I mean, it's easy to define blood pressure. You might argue whether it's 120 over 80 or 125 over 85, but it's a relatively known number, and you can test for it. I always feel this isn't to knock mental health. I'm passionate, particularly given my background and increasing understanding. I'm very pleased that the NHS now at least is supposed to put equal esteem behind mental health. And I actually think the whole country's in the midst of a mental health crisis. So heaven knows we should take it seriously. And we also know that if you've got a significant mental health disorder, it's a death sentence. It's the combination of diabetes and poor mental health is a 10 to 20-year death sentence. So we should take it terribly seriously. How would you define good mental health?
That's a very good point, actually, that you made. I think particularly what I like with what you said, that is if you haven't experienced mental health difficulties, it's hard really to see what a good mental health is. And until you've recovered from having a mental health difficulty, then it's very easy to kind of see as to this is life, really, and this is how I should be enjoying life. So I think if a person like yourself were asking me about it, I think one thing is that it's basically a combination of it's a holistic view of looking at what a good mental health is. It's like looking at the emotional, psychological, and social and relationship well-being. It's essentially like how resilient a person can be, and how one can bounce back from adversity and be able to recover, or be able to deal with the conflict, for instance, or the difficulties that they may face.
Yeah.
Being able to have this good coping skills in any adverse situation that we may encounter. We all encounter different stress in our lives, be it work, in our social life, relationships. If somebody were to cut you whilst you were driving, then people can get stressed. It's about how we deal with that stress, and how we emotionally have this self-awareness of how we interact with the world and how we regulate our own emotions. And then there's also what we call like having this fulfillment in life, not just about your mental well-being. It's about whether the purpose that you have in life is you are able to achieve it without having the difficulties in coping with any hurdles that you might encounter. And what, in my view, the most important as well is how your physical health interacts with your mental well-being as well. It's I remember in our training days, we always have and even now, patients presenting with physical health difficulties, and yet any tests have been all unremarkable or doesn't really explain the physical health difficulties that a patient might present with. And personally as well, I remember having aches and pains, and particularly focused on one area of my body, for instance. And I think having a good physical health along with the good mental well-being are both interlinked, I would say. So having a poor physical health, you might want to think, is there anything happening in terms of your mental well-being? So having good physical health is also akin to having a good mental health or mental well-being as well.
How objectively do you think we can actually measure? So if we talk in fairly general terms about having good mental health, and I mean, I'm not disagreeing with anything that you say, how objective do you think we can be? Because again, I'm not knocking the field. It's a field I'm passionate about, but you think about diagnosis, and you can diagnose hypertension. I know I'm talking about this, but it's an easy one to understand. You can define it as an upper figure and a lower figure, and you can see a downward trajectory. My impression, and please correct me if I'm wrong, that we define poor mental health in terms of a sort of constellation of symptoms, and we try and there's an extent to which perhaps we're putting a square peg in a round hole. So we kind of personality disorder, depression, bipolar, schizophrenia, schizoaffective disorder. My subjective impression is that none of these things are absolute. That you get a constellation of symptoms, you try and fit the individual into those symptoms and treat accordingly, and then as you see symptoms resolve, you see that as progress. But also you often see people with multiple diagnoses and changing diagnosis over time, which again doesn't mean that everyone's got the diagnosis wrong. For me, it's because as symptoms change, you perhaps no longer fit your constellation of symptoms no longer fits diagnosis A, so maybe it's diagnosis B or C. To what extent do you think that's a reasonable way of describing it, or do you have a completely opposite perspective on it?
Not completely opposite at all. And I think how you described it is what the general understanding is really. And you're quite right. We don't have like a scan where we can put a patient under and to determine, so this patient A has schizophrenia and patient B has schizoaffective disorder. So we have years and years of training in order for us to be a psychiatrist to where we are. So history and examination is our main bread and butter, really. So we are, as psychiatrists, are trained and are experts in conducting a focused or general history in order for us to determine the symptomatology that the patient presents with and the signs that other people see in that particular patient. How does that fit in with the diagnostic criteria that we know in the psychiatric field? So it involves assessment of patient by way of an interview and looking at collateral information, for instance, maybe speaking to the relatives, friends, family, looking at GP records, general practitioner records, or any other psychiatric records that we may have. So that's one step that we do.
Yeah.
And second is observation. So it's important, like say, for example, if somebody's mental health symptoms is such that it does not really somebody has a psychotic disorder, but we're not really sure, is this just a drug thing? Or is this a genuine a schizophrenia, for instance, or schizoaffective disorder? So then we can follow up patients if it was in the community, do maybe like a weekly assessment, or if somebody is so distressed that they cannot be managed in the community, they can be admitted to hospital, and then that way 24/7 we can do an assessment of the individual, not just by the doctor, but by the nurse, the occupational therapist, the social worker, the psychologist. And this is what we call like an MDT, or multidisciplinary team approach in assessment. And then once we have a view of the diagnosis that fits in with the diagnostic criteria that we know, so we can offer the treatment that is well known for that particular disorder. So in general term, antipsychotic, anti-manic, mood stabilizer, or antidepressant, or anti-anxiety type of medication.
Yeah.
And giving medication in itself is a form of assessment. It's the symptoms where to resolve or to change from day 1 to day 15, for example. So that forms part of our assessment as well. So that's how we basically do our day-to-day job in doing conducting an assessment and generating a diagnosis.
And I always, again, wrongly, I feel that psychiatry has kind of been the poor relationship of medicine. It's been derided or looked down upon. So it's a particular choice for a doctor to take that as their professional path, one which I actually applaud, as I say, because I think the nation's metabolic health is terrible, but our mental health is worse. So what made you pick that route? Why that rather than something perhaps more immediately apparent?
But perhaps more like a doctor. Which is what our immediate family always says. Why are you not doing cardiology? Why not surgery? Why
be a proper doctor?
Right, be a proper. Why do you got a stethoscope around your neck and all
Yeah.
Funny enough, that I got into psychiatry by accident, really, if I can use that word. So having come to this country, it's difficult for those who haven't trained in a particular country, but in UK for this instance, to get a job straight away. You need to have some kind of like shadowing experience. I did want to do internal medicine or emergency medicine in the past, but when I was in the Philippines, I wanted to do surgeon, but I'm like 6'5". I couldn't stand for like a long time. Then I thought surgery is not good for me, so I thought internal medicine. But then during my shadowing experience, I did shadowing in psychiatry in an inpatient ward, which I truly enjoyed. And then I decided that this is the field that I really wanted to do, and then applied for training. But when I did do that, I wanted to. I'm very interested in like the forensic science. Ever since I was like young, I was so fascinated about investigative work. So when I heard there was a forensic psychiatry, I was so excited about it. And then I thought that forensic psychiatry involved investigation of crime.
Yep.
So just like CSI, for instance. And lo and behold, it was quite different. So I did, in our training, you have a taster sessions of different fields of psychiatry. So when I did 6 months, I truly enjoyed it. Although it's not a CSI, so we do a little bit of investigation as well. So why is this patient, 2 schizophrenic patients, one committed crime and the other hasn't? Why is that?
Yeah.
So I think that forms a part of the investigation, which I truly enjoy. So that's a joy of my career life, shall we say.
And where do you think the NHS talks about parity of esteem, which for the uninitiated means that we take mental health equally seriously to any other form of illness? Lots of lip service on that. Do you think we're getting things right, or do you think that's still broadly lip service and actually it's not given the parity of esteem that it should have?
I think personally, having worked in the NHS, I think it's very fortunate that we have different services that deals with different types of or different stages of the mental disorder, shall we say, if I can put it. So we have children's services up to like the adult services, and then we have secondary services, tertiary, and so on and so forth, like highly specialized services. So I think recognition is there, and there's quite a number of like research that has been conducted in order to inform different treatment pathways or different investigations that may be necessary for a certain individual. And I know that the government have also put enough effort in order to maintain a good mental health of all of us here in this country. So I think the recognition is there, services are available, and of course, and this is no secret, but funding is not enough in order to have appropriate number of beds, for instance. And I suppose the same goes on in every field of medicine within the NHS, and mental health does take a hit as well. But in terms of recognition, I think it is well recognized in my view.
Good. Do you? I mean, I think the whole nation's in a mental health crisis, and we know that we're in a metabolic health crisis because you don't need a stethoscope. You just need eyes to see. You know, you go back and look at any World War I movie. There's no fat people.
Okay.
Look at any high street now, and we're getting fatter and more diabetic by the day. I mean, it's unmissable. And people say, oh, well, it's because we don't move very much. Well, next time you wander around your high street, look at the bloke digging the road, or the bloke digging the garden, or the bloke climbing a ladder. Those people are moving all the time. We've got a building team at the moment doing some work for us. They're all podgy guys. And it's not that they're not moving. So something else is going on. Do you agree with me that there's a kind of, yes, there's a what I call diabetes crisis, but to me, there's a hidden mental health crisis, which makes the diabetes crisis, and are they related? I would argue they are. Interested to know your perspective on that. That we're suffering from a mental health crisis in the country.
Absolutely, I completely agree, and I think the mental health crisis leads to a range of physical health disorders, neurological disorder, metabolic disorders, as you described, and the other way around. Metabolic disorders or physical health disorder leads to a range of mental health difficulties that patients experience as well. And I think, and the reason you and I have met now is you mentioned public health collaboration, and that has certainly kind of opened my eyes into like a different perspective of how we can look at mental disorders and how we can explain certain things. Really, I'm not suggesting that we ditch all the training that I've endured and enjoyed as well at the time, but I was just looking at like a parallel explanation to how people are experiencing the way that they are presenting to the world, to themselves, about themselves, and in their interaction to other people around them. Really, be it like a risk to themselves and to others, or a disruption in the social interaction with others. So I think, absolutely. So I think that it's a very important point that you brought up there, Graham.
You know, in such training as I was given as a community pharmacist, look, obviously we're bumping into people's mental health problems, or not in the specialized area that you do, but most of these people live in the community all the time. I'm well aware that almost the entire country is on an SSRI or a statin, or ideally both, right? I'm not seeing big improvements in either their people's cardiovascular health or their mental health. In your training, I mean, this is a famous quote from Georgia Reed, that last time I looked, the brain was connected to the rest of the body. But in the way that we're trained, it's completely not discussed, is it? There's no sense of that connection, and no sense of, maybe if you're diabetic, you're also more likely to be depressed, and maybe if you're depressed, you're more likely to be diabetic. And my perspective on that has been radically changed, I suppose, initially by bumping into Chris Palmer and brain energy. What's your take on all of that? Do you agree with me, or have you got a very different view of it?
No, not at all. I think if we just put psychiatry aside and look at the medical curriculum, we have not been taught nutrition at all, or how the nutrition might affect our physical health and mental health, for that matter. I think it's all to do with genes, genetic risk factors,
Yeah.
chemical imbalance, if I can put it in a very general perspective, and how the chemical imbalance generates different kinds of physical disorder or mental disorder, or the connection between the two. And let's give medication in order to balance the imbalances that we know.
Yeah.
We think that is happening because there's no scans that can specifically pinpoint that this is schizophrenia or this depression. And also other non-pharmacological treatment like CBT, which is cognitive behavioral therapy, which is talking therapy, might help people address their difficulties by helping them to think differently. And then that might help them move on or improve their resilience, their overall mental well-being, their capacity to deal with stress, for instance, and all that. And I think what's opened my eyes, as did you as well, Graham, is that this alternative, I was going to say alternative thinking, but it's not alternative thinking, but it's an explanation as to why is the imbalance happening in the first place.
Yeah.
And I think I always, when I give talks, I always say that we are good at treating the smoke, but not the fire.
Yeah, lovely way of putting it.
And I know David Unwin used this analogy about why do we just switch the tap off? And I'm sure we're going to get into that in a moment. But what tap is it that we're talking about? Why not just the tap off instead of getting a bucket in order to get rid of the flood or the water that's causing the flood in the house? So I think this is an era, and I know and I'm very excited about, because lots of studies are now being done and lots of articles are being written, be it a case series or anecdotal data to like a number of trials, into looking at how nutrition is affecting our metabolic health and thereby affecting our mental and physical health, either individually or combined together. So I completely agree with your piece there.
And so because we talked about the diagnostic criteria and the sort of diagnostic pathways in which you, as you said, you talk to the patient, you talk to the client, you get an assessment of how they're feeling about life in general. You might get 3D input from friends, relatives, family, to create a kind of that kind of three-dimensional model of how they are mentally. None of that involves what your diet is.
No.
And I don't think most, and tell me if I'm wrong, most psychiatrists wouldn't even think to ask. You might ask about substance abuse, but I would say most ultra-processed food is just another form of substance abuse, but it doesn't get asked about.
No.
So to what extent would you agree with me that so much of this is driven by metabolism? And if your metabolism is failing in your cardiovascular system, you're at risk of hypertension, stroke, heart attack. And if the metabolism fails in the brain, it could lead to any of these disorders of depression, schizoaffective disorders, schizophrenia, or ultimately to longer term damage like Parkinson's or Alzheimer's or these different dementias. To me, these things are all intrinsically linked. They're all different expressions of the same fundamental problem at the level of the cell, and then that sort of multiplies up to the organism. Is that a naive view, or would you go? How far down the track would you go with me?
I think if we talked maybe 5 years ago, and somebody were to tell me that it's all to do with diet, then I think people would say that what are you talking about? There's no link. How can you say that diet has linked to our mental and physical health, or mental health and physical well-being? So I think what might be useful in order to answer that question is to talk about a little bit about my journey and as to how how I got into this and how it kind of opened my eyes, and the common adage is that got myself into a really big, deep rabbit hole, so to say. So
We're both in the same hole, I think. Pedaling furiously.
That's how we probably met. I thought I recognized you, Graham. So essentially, I mean, I have no shame in talking about my personal experience. I used to be 22 stone.
Wow.
So I think for that to be in kilograms, I believe it's about 135, nearly 140 kilograms in weight in the past, with a big waistline. This was in the Philippines and all that. And during my last year of training, I saw this. I will never forget this interaction that I had with him. There used to be a quite big nephrology or kidney specialist trainee above me. I was a student and he was above me, who's lost a lot of weight. And I was like, this was in 2000, and I was like, how did you do that? And then he talked about the Atkins diet. So he then gave me his diet plan as to what he ate religiously on a day-to-day basis, breakfast, lunch, and dinner. And I will never forget that during my training, even on nights, I will eat exactly as I was told, and I shed like significant amount of weight. But fast forward 20 years, right? Or actually, no, fast forward 19 years, because it was last year when I attended the public health course. Not once I've actually dug into it. So why did I lose that weight in the first place? Why did that happen? I wasn't like I didn't ask like as a scientist to actually help me understand. Hang on a second, Sunny. Why did you lose that weight? Why is that? Because we've been told that in med school and nutritional school that fat makes you fat. So you avoid fat. You must take the fat off your bacon, the skin off your chicken, and eat lean and all that, because that's what we've been told, that fat makes you fat, and live your life drinking skim and have grains and all that. Right. So I've suffered bouts of depression with water medication for a number of years. Although I did lose weight, so I suffered with like sleep apnea as well, for which I was on CPAP machine, the continuous airway pressure. I wasn't like morbidly obese because I had lost a bit of weight, but then I had those complications, some allergies that I developed that I didn't have allergies before, to prawns, and then some skin condition like eczema type stuff. So then I still yo-yoed. Sometimes I'll eat rice, which is a staple starch, staple carbohydrate for Filipinos, rather than chips in this country. So I will still, sometimes I'll eat it, sometimes I won't. So my weight will go up and down. Mental health still not good. And then I attended the conference, and then the digging of the rabbit hole began with reading the Ben Bickman's book, Why You're Sick. And it all brought me back to med school about what we were taught there, and then now relearning the biochemistry of what is the physiology of our body? How does the body react to a bite of your burger? What happens to the bun? What happens to the ketchup and mayo or mustard, the pickle, the egg, the cheese, the patty, the beef patty, and the Coke and fries they eat? What happens to those individual components in our body, and what do those macronutrients do to our physiology of our body, from the tongue down the toilet? And that's how I got to do tons and tons of readings and research, articles, listening to podcasts, watching YouTube, meeting people like yourself and the public health collaboration attendees, delegates, and all that. To help me understood that the chemical imbalance can be explained as the smoke and the fire that causes all these neurotransmitter imbalances that Georgia Eve talks about a lot in her jargon called the chymeric pathway, which is like the imbalance in the glutamate, the dopamine, the GABA, and the melatonin. Now, how does that all happen? It's because of like the root cause being the insulin resistance, and which then leads to a whole host of pathway of complication, destruction, which is like the oxidative stress, which then leads to the mitochondrial dysfunction, which Chris Palmer, you referred to earlier, has talked about. And then like you have the glucose hypometabolism and then neurotransmitter imbalance because of this radical oxygen imbalances that happens alongside it. So treating with medications, yes, it might balance the imbalances that we talked about, but then it will continue to occur. Why is that? It's because of the insulin resistance. Why is the insulin resistance happening? It's because of the food that we've been eating. So which of those macronutrients or the combinations and other additives that or adulteration of the macronutrients that then leads to what we call industrially produced palatable substance, which is also ultra-processed food. I won't call it food, it's substance that's made palatable. How does it lead to that the insulin resistance? And I think this is where I think the key is in order for people to be taught or information to be disseminated. And it helps open people's eyes if they care to listen, for example. So I think this is I think where we are, and how we get to talk today in your show. I'm sure I know that you and I have the same aim, is to like help people and open their eyes as to why we're getting these disturbances, these disorders in the first place. It's a long-winded answer to your...
No, well, because the body's complex. I mean, if you look at an individual cell, even an archaea, which is one of the most ancient cells, and they're single cellular organisms, the processes that go on to maintain the internal environment of the cell as it's intended to be, what we call homeostasis, is hugely complex. And then you get to an organism as complex as a human being with 100 trillion cells, and we think that's the answer. But actually, you've also got the microbiota, that incredible colony of bugs that resides within us. And people don't realize that 90% of our immune system is in our gut, and that most of the serotonin, which is the neurotransmitter we all talk about, SSRIs, which increase the, I was taught that they increase the levels of serotonin in the brain. I'm now not sure that that's how they work, but it seemed plausible at the time. 90% of the serotonin is in the gut, generated by the bugs. So has that modified your approach then now? Do you look, I would say, more holistically? So when you're talking to a patient or a client, you do these global assessments about symptomatology. What would your lifestyle approach be now? Where would all that fit into not only diagnosis but treatment pathways in the way that you now work?
Absolutely. So I think what's important to be discussed here really is that we as doctors, and I'm not sure how it's in the pharmaceutical world, but we as doctors, we follow guidelines. You might have heard of NICE guidelines, with the National Institute of Clinical Health Excellence guidelines. We have like other guidelines. So we have the MODSI guideline, you have the British Association of Psychopharmacology guidelines and all that. And I think if you go against the guideline, then you have to have a good explanation for it. So I think that's one thing. So the difficulty we have is that, and the guidelines dictate the policies and procedures of the hospital, right? So for you to sway from the guideline, you have to have good reasons for it. And because the change will not happen automatically within a day, like, oh, Dr. Kaler said we need to avoid ultra-processed food, or we need to increase someone's protein, fat, and limit someone's carbs. oh, let's do that tomorrow. It can't because hospitals follow guidelines.
And their food is the worst in the world as well.
That's right. So hence, I think you asked me, how do I change my practice and how do I change my approach? First things first is modeling. And I think modeling is really, really important. And I think people have noticed a change in my outward appearance because of the weight that I've lost and all that. But for those who know me personally, they know that how I've improved my depression and also I think that's modeling. And then people ask questions, how do you do that and all that? The second is active dissemination of information, advertising myself. Can I come and talk to you about nutritional psychiatry or metabolic psychiatry? And then people start to generate questions. And then what will then happen? And my aim being is to help start after education to start a form of study. We call it maybe like an audit or a service evaluation. We have patients who have been admitted on such and such weight, but then exponentially in 5 years' time, their weight have increased. And why is that? Is it the medication? Is it because they're not moving more and because they're not eating less? Or is it to do with other things that we've not been talking about? The policy that we follow, which is like ultra-processed food, so long as it's low fat and low in salt and all that kind of stuff. So I think, yes, I think at this stage, it's all to do with education, dissemination of information. However, it's different if you're working in the community, because I work in Rampton, it's a closed community. Our patients can't go to Aldi to do shopping by virtue of them being a high secure patient. They are locked in a high secure hospital. But if you're in the community, it might be slightly easier. It will be slightly easier because you can give patients information, and then the patient can go to Aldi or Lidl. And I'm just for your audience, I'm not paid by Aldi or Lidl to say the thing. But what I'm saying is that the cost is important because of equality and a difference in economic situation of our society. But they can then experiment on food and do elimination type of diet, as Georgia says in her training as well. So I think there are two ways of how one can change their practice in the community and in the inpatient setting.
And as I often say, many of us say this, once you see this, you can't unsee it. So I find it impossible to practice pharmacy in a conventional way now. And I look at all these drugs and I hold my hands and thinking, really, we're just treating symptoms, trying to suppress them. Within my private practice, I can advise people to make changes, and even within our NHS practice, we try and encourage people not just to rely on the medication, but also look at their lifestyle, sleep, exercise, alcohol consumption, and the rest of it. In a very closed environment like Rampton, are you actually able to have any influence on the whole metabolic approach, the food that people are provided with, their nutritional status, and get them to make changes and then show, look how much better I look and feel having changed my own personal way of eating, which is exactly the same for me. I talk about that. I used to be always hungry and always fat, and now I'm neither. And I talk about it. I feel like I've escaped the tyranny of food. Are you able to make changes in a huge environment, very sort of organizationally complex structure like Rampton, or do they just say no, just follow the nice guidelines and shut up?
I think the very short point that I would like to make is at the moment is you can't just make the change quickly. That's I think I just want to lay the ground there. The change will not happen quickly. This thing that we've been led to believe has been going on since the 1830s. like from the Seventh-day Adventists, and then comes Ansel Keys, and then the McGovern Committee, and so on and so forth. So we are not going to change people's viewpoint in one day. I think that I just want to put that there. But the pie in the sky, I think, an analogy that I can use it is that the change will happen in small steps by way of educating people or providing them with the information. And that's what's happening now. So there are a series of sessions that I hold for the staff members, right? Not the patient, but the staff members. Because I think if the staff members who are with the patients 24/7 rather than the doctors, so I think they will be able to, if they change themselves, like I said to you about the modeling, then patient will say, oh, how did you do that? You know, how is it that you're not always hungry? You used to eat Snickers bars every 2 hours. How come you're not doing that now? I'm exaggerating. But so that's number one, so the modeling bit. And then second is, you asked me earlier, what's my day-to-day work look like? One of which is like management, like attending meetings. One of the meetings is about weight management, the obesity management group, involving the dietitian, the food, the canteen, the food supplier committee, for example, and other higher up managerial, like the quality matrons, and then having those series of meetings talking about the same thing that you and I talk about. Yeah. Because I don't blame them, because I'm a doctor, yet I was told fat makes you fat. What more the general public or staff members? I don't expect them to kind of like learn the same thing. Yeah. Immediately within a day. So yes, it's a small step that I'm doing.
And are you able to make those changes directly with patients, or to what extent? To what extent can you? Because you're obviously not dealing with everyday middle class people who've got lots of freedom. Their Brampton is not your normal environment. But is it feasible to help them make those changes so that they're on their journey of treatment and medication and CBT or whatever it might be? The dietary aspects of that. Are you able to play that in?
I'm able to provide them with the education, right? In terms of the changes, it depends on whether the food supply is changed or altered, or if they're given a choice. Yeah. But all to do with choice. So if you have a choice of jacket potato or baked potato for lunch, or as opposed to like a chicken breast and green beans for lunch. Yeah. If they have a choice, then I think once patients have been educated, then I think they'll be able to make those dietary options in their menu that they're given on a day-to-day basis. So that's that. And also giving them choice in the patient shop. If we can change like the patient shop, or again provide alternatives to what conventional choices that there may be, then that's the only way that we can make change for our patients. However, if the knowledge has spread, then there can be a way for how the kitchen can start producing alternative diets. They might call it keto diet or low carb diet, or something similar, and then patients will be able to enjoy variety and options. So at the moment, I think options not there. I think the next step forward is providing options.
And how do your professional colleagues view this? Do they just think, oh, Sonny's gone a bit nuts? Or do they think actually maybe he's got a point and we should listen and perhaps make some changes of our own? What responses are you getting?
I think when you say colleagues, you mean doctor colleagues?
Doctor colleagues and other professional colleagues, and also then the rest of the hierarchy. But what I feel is health professionals are incredibly bright people. And we've got tremendous knowledge and tremendous training. And at a certain point, all of that, as indeed myself, for 25 years, like I practiced conventionally, everyone should have a statin, avoid red meat, fat will make you fat, all of the rest of it. And then but because of my core knowledge, once I learned that that was all rubbish, but I had this really fundamental core knowledge, I could reverse that and learn quickly. And once you've made that change, you just can't go back. So I guess it's that tipping point, isn't it?
Absolutely agree. I will never go back to how I used to eat before, because all those things, the metabolic or physical health that I mentioned earlier, are all reversed.
Yeah.
So I'm not on any medication whatsoever, and the apnea machine is ready to be returned back for any other person who might need it. So I think the conventional thinking is very hard to shift.
It is.
Even with modeling and even with education. So yes, I have been called nuts, maybe like a similar or alternative phraseology, if you like.
Yeah.
But I will not stop, because I want people to feel the way that I feel. That I want people to live metabolically healthy, if I can say.
Yeah, it's a great way to live, right?
Absolutely, because I think, again, going back to like personal experience, it's really unfortunate that my father, who died at a very young age of 53, was told to just keep having insulin and just, you can adjust your carbs. It's okay to eat carbs, you can just keep having insulin. And it's all developed a whole host of, I would say, microvascular complications that then led to kidney failure, needing dialysis, heart failure, and then to its eventual demise.
Yeah.
That's what I want to really reverse, and to help people understand that you don't have to suffer the way that my dad suffered or I suffered. So hence why it's going to take time. I haven't lost hope.
No, you seem very optimistic. You mentioned at Rampton that you have this group of patients who also have hearing difficulties.
That's right, yeah.
So I was quite taken by that. I know we were chatting before. And tell me a bit about more that, because that's a fascinating area which I know nothing about, but I'm sure you can draw all sorts of things out from that.
Absolutely, yeah. So I got into this role since 2019, really. I shadowed my predecessor as part of my training, and it really fascinating. So when he retired, I applied for the job, and to this date, it's an ongoing learning curve for me. So I think the best way I can describe it is that, say, for example, you must have spoken to your clients, if I can use that word, or patients before, who can't speak English, or who are foreign language speakers, right? So the usual thing that you and I would do, or any people would do, is perhaps maybe you could find another clinician who speaks that particular language, and then do the assessment that way, or have the conversation that way. But the more common trend is that you get an interpreter. You book an interpreter either via phone, video, or in person. Because the assumption is that the foreign language speakers have their own native language, have their own innate native language.
Yeah.
Okay? So everything that you and I are talking now can be then interpreted in French, Italian, Tagalog, Hindi, Punjabi, whatsoever, because there is the assumption that they are born with and have grown up soaking up their own native language. But the same assumption cannot be made for deaf individuals, because deaf individuals have not had the opportunity to learn, to soak up language from day one, even when they're in their womb or from their birth, particularly if they're born deaf. And they've lost the opportunity to soak up, to assimilate language of any form whatsoever. And what then happens is that they develop what we call like a language deprivation syndrome. So it results from this a dysregulated development of language, because they haven't been exposed to any form of sounds or voice or hum or hymn or whatsoever. So the brain development is such that they haven't developed the language center, if you like, right? That then leads to a whole host of cognitive or neurological development or dysfunction as a result of this language deprivation. So that then leads to problems in learning, problems in social interaction, problems in communication, because the first critical years of language development is the first 5 years of the child's life. After that, learning language can be very, very difficult because of just the way how our part of our brain develops as we grow. Okay? So the analogy that I give to people is, have you recently learned a new language at all?
It's a lot tougher at my age.
Right? So if you try to learn a new language, or if you ask people who learn new language, you ask them, how easy was it? It's extremely, extremely difficult. It's because our neural pathways have already been developed in order for us to use English. In my case, was Tagalog, which is a Filipino language. So that's been developed. So anything that you learn on top of that, it takes a long, long time. So it's the same with the deaf individual. The first language development has not happened. Anything they learn on top of that, it's like as if you're learning Punjabi from tomorrow. So that's one thing. And because of this language deprivation syndrome, there are a whole host of problems that comes with it that leads to the problems with narrative conversation. For you to have a narrative conversation, you have to understand the concept of time, the concept of why this thing happened. If this occurred, then why hasn't that happened? And the concept of sequencing, and that is lost with people with deafness, and that then leads to like all this what the language deprivation that I've talked about. So it's really fascinating, and there's a lot of myths that have been untangled. So it's like, for example, that deaf people can read and write. But no, their first language is not English, so no, they can't read and write, right? Unless they've been picked up from the very young age and developed and received speech and language therapy. That's different. So you just have to shout for the deaf people to hear. So there's a lot of like these myths, and also a lot of nuances. No two deaf people may have like the same language need, or language acquisition will be different. So the signing style, British Sign Language, will be different from one patient to another. So these are like the cases that I deal with as an inpatient or all over the prison in England.
So you've kind of got some form of sensory deprivation syndrome. Is that a fair way to say it?
In terms of the language, in terms of the acquisition of the language that has led to the deprivation.
And then what is the sequelae of that then? So what's the end result of that?
For those
that presents itself when you see the patients or clients.
For my case, so a lot of them usually, unfortunately, get picked up once they encounter difficulties in their life, be it with the law or with their social relationship, with their employment history or whatever, because of their difficulties in interacting with other people. And the interaction is not their fault, it's because of the lack of understanding from other people and from them to other people in front of them. So I think, and then once they start developing or start encountering problems in either the social, economic, relationship, mental health, physical health, and whatever, our end is kind of like the end bit. So once they've started getting into trouble with the law, for example, and then we pick them up in terms of providing them with the support following an assessment treatment in order to help them develop their linguistic skills again, and to help them develop all the necessary necessary things that is required for normal or healthy relationship or healthy interaction with others. So I'm talking about like emotional regulation, for example, coping skills, what is the right and wrong norms of the society. So, so that's what we do, in addition to reducing the risk towards others.
That, I mean, it must be in some ways very difficult, but also quite a fascinating area to work in, I would imagine.
It's very challenging.
Yeah.
Everything takes longer.
Yeah.
Because what might be an easy word for you and I to understand can take days for some deaf individuals to understand. So, for example, if I ask you explain parenting or explain what is love or what is adverse effects and all that, I can explain it to you in 1 or 2 words, perhaps in English, but try explaining that to a deaf individual who have no language use or limited BSL use, and that's where the difficulty lies. And that's just like 1 word. And try schizophrenia.
Brilliant.
Metabolic syndrome. Try explaining insulin. What is insulin? And
Yes.
how the
I spend my life trying to explain what insulin is.
human population is about
Yeah.
more.
Yeah. Fantastic. You overall seem very optimistic about everything, though. Is that right?
I am, because I've done it for myself, and
Yeah.
I'm excited to help people about it, friends, family, neighbors, and all that. But still, you get resistance, but that's fine. It's going to take time.
I call it insulin resistance.
That's a good one. I think I might borrow that.
You heard it here first. Yeah. I mean, I think we're at a tipping point. I think with all the work that Chris Palmer's doing and the Bazooki Foundation and the foundational work that's happening worldwide now and the role of metabolism playing into everything, I'm optimistic. And I mean, certainly in my professional practice, I'm enjoying it more than I ever have. Moving away from spooning tablets into people while they just got fatter, sicker, and more diabetic more slowly, to seeing revolutions in their physical and mental health within weeks, and the light coming back on. That's kind of what we all came in as health professionals to do. So yeah, I think I share your optimism, but we know we need to keep going.
Absolutely, I completely agree with you. And I think this type of conversation that we're having is one of many ways, really, and disseminating information by way of sharing articles, presentation, inviting people to conferences, forwarding podcasts or YouTube clips, and I think it's a way. And then I think what we need is a sense of curiosity. I think when people, there are 2 camps. Really. There are those who say that, oh, look at all this weight that you've lost and you appear more chirpy, what did you do? And there are those who are like, oh, okay, good for you. So, I think we need to change those good for you people to say, what did you do? Yeah. And I expect skepticism majority of times rather than immediate acceptance, because like you and I, we've been told that the norm is to have oats for breakfast, for example. You know what I mean? So I think it's going to take a while that for people to hopefully a light bulb shining.
Light bulb moment, absolutely. Which I think is a great way to wrap up. Is there anything else that we haven't covered that you want to add, Sunny?
No, nothing really. I think you've asked a general and specific points about my journey and as to how we ended up like talking today. But I think it's been a great opportunity. So thank you so much.
Brilliant. Okay, well, lovely to see you again, and I'm sure we'll be in touch in the near future for a low carb keto meal.
No, I'm sure we will. Thank you.
Okay, all the best.
If you enjoyed the podcast and want to find out more, join our Wellness and ProLongevity Facebook group. Don't forget to subscribe and follow so you never miss an episode, and maybe share to friends and family who might benefit. Finally, if you think you might need help with diabetes, heart disease, or any of the other diseases we discuss, then book a free consultation with Graham. There's absolutely no charge for this, and we would never put you under any pressure. What do you have to lose? Bye for now, and see you for the next episode.